Dear colleagues and friends, ladies and gentlemen, welcome to day 3 of TIO. These last 2 days went by like a hurricane. I remember the first day with a ton of highlights, but just to name a few, the comparison between MitraClip, the technique of a MitraClip as demonstrated by the folks at Emory, and then this spectacular Pascal case to correct tricuspid regurgitation from Leipzig were quite stunning and really illustrated the differences of these two technologies. The second day we focused on coronaries, and I think one of the main highlights was that, well, you can do high-risk PCI with different devices these days. We have the IVAC, we have the Impella, but also the importance of coronary physiology and imaging, invasive imaging. I think in this day and age, PCI in general requires these features and tools, and whoever says differently, don't believe them. Now, full steam ahead, day 3. We're gonna shift gears, we're gonna have some controversies and live cases, of course, and for the first time, we have a keynote lecture, and it is my honor to receive Dr. Marty Leon from New York to present this first keynote lecture. So without further ado, very excited, let's get started with day 3.
Hello, everyone. Live from New York. It's TIO Day 3. It's a fantastic, fantastic day to be here with you. We have had an amazing 2 days of live cases, wonderful lectures, and today we have an incredible panel that I want to introduce to you. I have with me Dr. Marty Leon, live from New York, right here with me. He's going to give us the keynote lecture for the first time, which is fantastic. He's the mentor of everyone, hundreds of thousands of people around the world mentored by this man. I'm one of them, and I'm so proud to be here today. Azim Latib, Director of Interventional Cardiology from Montefiore. Didier Cheche, Head of the Structural Heart Disease Clinique Pasteur. And Holger Thiel, a great friend and wonderful friend from Leipzig Heart Center in Leipzig. Welcome, all of you. Hi, guys. How are you all doing? Ready for TIO Day 3?
Yeah, sure.
Looking forward to it.
Can't wait to see you. Well, before I introduce Dr. Leon, I want to first introduce our first poll. Transcatheter heart valve durability remains a major limitation in TAVR. Yes or no? Please vote. Without further ado, let's go to the keynote lecture today. Dr. Martin Leon, who's the founder and chairman emeritus of Cardiovascular Research Foundation. We're in those studios here with you today. He's built one of the most incredible not-for-profit centers dedicated to research, education, and a full commitment to mentees around the world. His work has been published around the world for many, many hundreds of thousands of publications. He's one of the most cited investigators in the world. And not only that, he's an innovator and an incredible, incredible person to work with. I know that wholeheartedly from my heart. But he is the one I remember over 25 years ago, sitting in the office, working very late at night, when he came into me and said, you know what, we're going to be doing transcatheter aortic valve replacements, and I thought he was having too much wine or something, and that this can't be true. And here we are today, where we are expanding indications, and he is really the father and the most, I would say, the most prominent person in interventional cardiology. Aren't we so lucky in TIO to have him deliver the keynote address in expanding indications for TAVR? Not only is he a founder of Cardiovascular Research Foundation, but he is an endowed professor at Columbia University, New York Presbyterian, and he chairs and leads the Center for Interventional Cardiovascular Therapeutics. There's so much to say, but you know what? We don't have time. We've got to go to this wonderful keynote lecture. Marty, it's so wonderful to have you. So glad to sit next to you, 6 feet apart, but very, very happy to be with you. Welcome.
Roxanne. Thank you very much. Certainly, Roxanne, that was a wonderful introduction, beyond my expectations. I'm thrilled to be part of this outstanding meeting. I want to thank Nicholas for the honor and invitation to give a keynote lecture, to our other panelists who I respect enormously. I truly enjoy these global meetings because for most of you who know me, I really do have a global perspective on the way we practice medicine and the way we bring forward technology. So the opportunity to interact with you is very meaningful to me. So I've been asked to talk about expanding indications for TAVR. And in typical fashion with TIO, I'm going to do my best to be a little bit controversial, a little bit aggressive. I am biased in that I'm an interventional cardiologist, although I will say that I've tried very hard to forward the notion that transcatheter therapy should be an open field, embraced by imaging experts, embraced by surgeons. So this is more of a ecumenical opportunity for people to take advantage of what are new, less invasive therapies in the structural heart domain. These are my disclosures, several of which are relevant to this presentation. So let me begin. I want to start by reviewing for you where we are now, then give you some insight as to what I believe expansion should look like, and then we'll go into some of the very specific expanding indication targets. So I usually begin by showing a slide of my colleague, friend, Alain Crebier, who I would describe as a first-in-man pioneer. This is 15 minutes after the first case he did back in 2002 in Rouen, France. Note that this patient was treated without general anesthesia, without transesophageal echo, was in cardiogenic shock, and rejected by surgery, had an ejection fraction of 10%, and was done via a transeptal approach. This is 15 minutes afterwards. And I spoke to Alan a few minutes after this picture, and we mused about what was next. Clearly, in the earliest stages, this procedure, this concept, was truly for patients that had no other options with regard to therapy and had critical symptomatic aortic stenosis. I don't believe that anyone could have predicted at that time that we would see such a rapid technology advancement and evolution, that we would see marked procedural refinements and simplification so that this has become a generalizable procedure, that there's been an avalanche of clinical evidence, and I'm going to focus on that in this presentation. The concept of the heart valve team has been now accepted and has become a uniform vehicle to be able to forward new therapies to patients. All of this has resulted in a dramatic reduction in procedural complications and improved clinical outcomes. This is from the most recent version of the TVT registry in the United States, and you see the highlighted yellow line is the trajectory of TAVR in the United States. You see that just after 2015, we crossed surgery performed for sole AVR in terms of numbers, and by the middle of 2018, even before we had approval for the low-risk indication, there were more TAVRs done than all of surgical AVRs, so a dramatic increase in the number of these procedures. If we project even further, it is expected that by 2025, that more than 3 in 4 aortic valve replacements will be done with transcatheter approaches, and I think that likely will be an underestimate. By the end of 2020, over 800,000 cases have been done worldwide with TAVR, cumulatively since the beginning, which is about a decade, and we expect that number will reach close to 1 million by the end of 2021. A striking evolution of a new procedure. I would argue this has been driven by evidence, by clinical research. David Capodanno, good friend, put together this catalog, and this is a few years ago, of the randomized trials that we were doing just in the TAVR space, 24 ongoing or completed randomized trials. In the last 15 years, in the United States alone, more than 15,000 patients in FDA studies, 10 randomized trials, multiple generations of 4 different TAVR systems. I'm most familiar, as you can understand, with the partner trials, but to give some perspective, more than 9,000 patients in 5 randomized trials, generating already more than 200 peer-reviewed manuscripts and abstracts. These are just some of the examples of the many manuscripts, and within the partner trial for the seminal publications, we've had already, in less than a decade, we've had 10 publications in the New England Journal of Medicine and the Lancet, to give you an idea as to how the importance of evidence generation has helped to drive the field. And that's resulted in a dramatic change in clinical outcomes. When we look at the first partner trial to the most recent partner randomized trial in low-risk patients, there is a 15-fold difference in the 30-day mortality of this procedure, which gives you an understanding of how quickly we have evolved into a procedure that is now safe. And that drives the concept of expanded indications. If you have a safe therapy that could be generalized, we can begin thinking about things that were more difficult to think about with surgical AVR as the treatment option. All of this has resulted in new guidelines in the United States recently in the last 3 months, in Europe coming in the next 6 months, which have established Class 1 recommendations for TAVR, certainly in high and prohibitive risk patients, but also in intermediate and low-risk patients over the age of 65. You can see that there are now so many Class 1 indications, all based upon the generation of evidence. So I still believe, as a clinical trialist and as a clinician, that we need evidence to change guidelines. We need procedures that can be generalized to be able to really project ourselves into the future and to try to explore more innovative and new expansion of indications. So how do we expand the future of TAVR? Well, one way to do it is to say, well, there's surgery and there's transcatheter techniques. We'll simply find ways to be able to get a bigger slice of the pie. Another way to do it is to say, let's grow the pie. Let's start treating different groups of patients that we weren't even treating so much with surgery before. And a third way is to do both. And of course, in my typical fashion, I'm going to say that we need to do both. We need to continue to evolve so that more of the procedures are done with lesser invasive techniques, and we need to expand the pie from the standpoint of greater access, new indications, to allow us to be able to treat patient populations that we were not treating with surgery before. So what are some of those expanding indication targets? I would argue that they fall into three zones. One is what I would describe as surgical AVR comfort zones. The other is upstream, or earlier TAVR treatment, and the third is new anatomic substrates. Let's begin with some of those surgical AVR comfort zones. And I want to start with low risk in younger patients. We've begun to approach this group, but we have not really penetrated the heart of low risk in younger patients. Bicuspid aortic valve disease as a parallel group of patients that are certainly many times low risk and younger as well, but have a particular anatomy. And then AS and concomitant cardiovascular disease, patients that have associated coronary disease, atrial fibrillation, multi-valve disease. These are generally groups that are largely treated with surgical AVR. In the future, I think these can be and should be expanded indications for TAVR. Let's start with the low-risk patients. This is a whimsical representation of the STS database, but it really does put in perspective. We spent the better part of a decade studying prohibitive risk, high risk, intermediate risk patients that comprise only 20% of the population of severe symptomatic AS patients who are receiving surgical AVR. So the holy grail really is the 80% of AS patients that receive surgery who are in this so-called low risk category. And these are also many younger patients. Well, it's early in the morning, so we'd be drinking that cappuccino, but in Europe it's later in the day, so you're ready for a pub break. So no matter how you describe it, the low-risk patients really are the heart of what we need to be considering if we're going to expand the indications for TAVR. Now, we published randomized trials in low-risk patients in 2019. And we've not shown these data before. These are newly generated. These are data from the TVT registry looking at risk categories as determined by the heart team assessment, low, intermediate, and high risk over the last 3 years. And you can see the ACC 2019 presentations, and then the FDA approval of devices in the US. This is all US data. You can see a dramatic increase so that by now, about a third of the patients are high risk, a third are intermediate risk, and a third are low risk. But over the past year, it's really plateaued, and we're not seeing as much growth in the low-risk patients. There may be a pandemic effect here as well, but I would say that things have plateaued, and largely because we're getting into the core of low-risk and younger patients. And there are some interesting clinical decisions that need to be made in the younger patients. So this is one of the ways to think of younger AS patients. It's a concept that we call therapy sequencing. In the older patients, we're generally talking about a single procedure. When you're at the age of about 65 or so, you're generally talking about 2 procedures over the lifespan of the patient. But when you're really in the younger patient group, 50 and above, you may be even talking about 3 procedures. This brings into play the issue of valve durability. And the clinical decision-making really becomes the ratio of life expectancy to known valve durability, and age is often used as a surrogate for life expectancy. So that's why it's so important for us to tackle and understand if we can use TVR in a meaningful way in younger patients. Now, when we talk about durability, we get back into definitions, and I have to credit ESC and EACTS for coming up with some more rigorous definitions of durability that have now been embraced and expanded slightly further in the VARC-3 document, which is about to be published. But we need these more detailed and prescriptive definitions of what durability means rather than just a patient either dying for presumed valve causes or having a reintervention, surgery, or otherwise. These are some new data from Sushil Kadali from the Partner 3 trial, looking at SAPIEN 3, looking at a propensity-matched analysis of 5-year outcomes with surgery, looking at the SAPIEN 3 valve, and you can see out to 5 years that from the standpoint of gradients, looking at serial echocardiograms, there's not much difference out to 5 years. And we feel fairly confident that up to 5 years, there's not much of a difference between surgery and TAVR. If we look at it using these very strict definitions of hemodynamic valve deterioration or bioprosthetic valve failure, the rates are very low and equivalent between TAVR and surgery in this analysis. And if we look at an expanded analysis, again from Davide Capodanno, if we look at patients out beyond 5 years, 5 to 8 years, we're still seeing very low numbers of structural valve deterioration and bioprosthetic valve failure that we think are equivalent to surgery. We don't have good 10-year data yet. We need more patients, but at least the early indication is that there's no very negative durability signal that should alert us that TAVR would be less durable than surgery from the standpoint of bioprosthetic valve failure. This is something we need to watch in the future. So getting back to this issue, what do we do with younger patients? Again, in more aggressive and provocative fashion, I believe you should start with TAVR. I believe that in the older patients, for sure, with a single procedure, even in the patients over the age of 65, I think starting with TAVR, to me, makes perfect sense. You may avoid ever needing surgery. And even in the youngest patients, it reduces the likelihood of surgery to a single procedure. So the key clinical issue is the goal to limit the number of open surgical procedures and also to respect patient preferences. So I feel in the future that a TAVR first strategy may become the preferred pathway for many younger AS patients. And we'll be discussing this certainly over the next many years, how to sequence these younger patients. Now, bicuspid aortic valve disease to me is a conundrum. This is just an example of some CT angiograms that Hassan Jalahaway has put together for a very nice JACC imaging manuscript showing the heterogeneity and complexity of bicuspid aortic valve disease. And these also appear in younger patients. There's no question that there's interesting data in high and intermediate risk patients, as shown here, this Yoon publication, well known, with bicuspid disease, indicating that there are morphologic determinants of poor clinical outcomes, calcified raphase, excessive leaflet calcium. But this is just the beginning. We need to do much more CT phenotyping to identify other anatomic risk factors for TAVR in bicuspid disease. And there's a host of new data in low-risk patients with bicuspid disease. These data published in JAMA Cardiology with the core valve recently published. It's a 150-patient registry showing excellent outcomes, excellent valve durability, and not much in the way of paravalvular regurgitation, even though minor PVL is still an issue. And then comparable to that is the embedded registry presented by Matt Williams and John Webb from SAPIEN 3, showing similar excellent clinical outcomes at 30 days and a year. Again, very good hemodynamics, even in a selected bicuspid population, and also not much in the way of paravalvular regurgitation. I do believe, I may be in the minority, that we still need randomized trials in bicuspid disease. All previous surgery versus TAVR randomized trials have excluded bicuspids, so it's registry data only. There's a major evidence gap. The anatomy is so heterogeneous and complex. We haven't really established the anatomic inclusion and exclusion criteria. The surgical outcomes, by the way, are excellent in this population with pretty good long-term durability, so we have a high standard to be compared to. And the TAVR outcomes have included increased complications, and the attempted comparisons with tricuspid valves really are confounded by a lot of case selection bias. Other concomitant cardiovascular diseases being explored, the complete TAVR trial in ASCAD certainly is going to be the largest randomized trial that we've ever seen in the TAVR space. Up to 4,000 patients just begun enrolling. David Wood deserves the credit for getting this off the ground. Patients with atrial fibrillation, we've completed enrollment in the WATCH-TAVR trial. So these are patients with AF and severe AS, another clinical conundrum, and we'll have results back in the next year or so. A very interesting study that Samir Kapadia has led. But perhaps the most interesting area in this expanding indication zone is what we call upstream or earlier TAVR treatment in both asymptomatic severe AS and what I would call at-risk moderate AS. So this is an interesting thought exercise that is derived from some of Philippe Généraux's work. We've been working in the green zone of severe AS with symptoms, many partner trials, many core valve trials done, US, Europe, everywhere. The yellow zone are some of the newer indications, what I would describe as upstream. Severe AS without symptoms, moderate AS with symptoms, studies like early TAVR, TAVR unload, and then we get into moderate AS in an at-risk population that may be even asymptomatic. And it's been a decade that we're moving in this direction. Right now, moderate AS without symptoms certainly is being treated standardly by so-called active surveillance or watchful waiting. We think in the future that may change. It may evolve into more population screening, but we're moving aggressively into this upstream earlier treatment direction. Part of this is based upon some of the interesting data that Philippe Généraux has generated that was published a few years ago in European Heart Journal, looking at a staging classification for AS based upon extent of cardiac damage. So if you look at patients that were in the partner trials, now these are severe symptomatic AS patients, by the time they get to treatment, 85% of these patients have significant cardiac dysfunction. Only 3% had no damage. 13% had evidence of LV dysfunction. But when you get to left atrial dilatation, atrial fibrillation, mitral regurgitation, more than half. Pulmonary hypertension, tricuspid regurgitation, another quarter. And even RV dysfunction, almost 10%. It's too late to be treating these patients. So earlier upstream treatment, we think, is going to be relevant. And if you use this classification and look at one-year mortality, it absolutely predicts what the one-year mortality will be. So we feel strongly that evidence to demonstrate that upstream treatment of these patients is going to be a meaningful predictor of better clinical outcomes. Now, turning to the asymptomatic severe AS patients, this is the most recent meta-analysis about a year ago, 9 studies, 4,000 patients with a mean follow-up of 5 years. You can see in every one of these studies, if you did surgery versus simply watchful waiting, there was a significant difference with a hazard ratio shown here. These are not randomized trials. These are more strategy trials, so I would not in any way describe this as definitive, but it's led us to the early TAVR trial. There are many other studies, smaller studies with surgery that are being done in various parts of the world. We have enrolled 779 patients through the end of March of this 1,100 patient clinical trial in 75 US sites that requires a treadmill stress test to determine asymptomatic status, and then goes through an early TAVR versus active surveillance phase with a primary endpoint at 2 years of a composite of mortality, strokes, and repeat cardiovascular hospitalizations. So hopefully in the next few years we'll have some definitive evidence in the upstream treatment of these patients. Now, Nicholas has really pioneered the work with AS and heart failure, and I give him all the credit for really coming up with the concept of the UNLOAD trial, which is really to take patients with moderate AS but have clinical heart failure and reduced ejection fraction who are truly a high-risk population, and to prescribe early TAVR as being beneficial. So the UNLOAD trial, which is now a 300-patient trial, about 100 patients have been randomized, is a study to again look at optimal medical therapy versus the addition of early TAVR in these patients, with a very interesting hierarchical composite endpoint that I think will give us very useful information in the moderate AS and heart failure patients. But I will tell you that all moderate AS patients should be considered for treatment. These interesting echo data out of Australia, not for the first time, but more recently, really have brought up the issue of untreated moderate AS being a fairly lethal disease and not so different than severe AS. So we are moving quickly, and there's a large randomized trial that is under review by the FDA right now to look at an at-risk population of moderate AS and randomizing them to upstream treatment. So classic moderate AS criteria with one of 7 at-risk features, either symptoms, AF, an ejection fraction that's below 60%, a reduced stroke volume index, diastolic dysfunction, increased NT-proBNP, or an elevated calcium score. That's about 50% of the moderate AS cohort. And these patients would be randomized to early TAVR versus active surveillance. So we're trying to develop evidence in this group. The primary endpoint is going to be a non-hierarchical composite of death, stroke, and unplanned cardiovascular hospitalization. So stay tuned for these kinds of studies in the future. So let me end by saying there are new anatomic substrates. And the first that comes to mind, of course, is aortic regurgitation. There is data with conventional TAVR systems not designed for this disease state that I would describe as being, at best, problematic. We've learned from some of the earlier studies, the largest series shown here by Yoon, of about almost 1,000 patients, showing that there are challenges in this patient population. The annulus size is often large. They often have concomitant aortic dilatation. You've got insufficient anchoring due to lack of calcium in the aortic valvar complex. There's a lot of migration and embolization of these valves that were developed for other reasons. Residual AR, pacemaker rates have been higher, and 30-day mortality, from my perspective, has not been acceptable. So there is a dedicated device that has been developed for this purpose and for AS, but mainly for this purpose, the genopericardial transcatheter heart valve, and this is moving ahead very quickly. It has a unique technology using locators to be able to position this device deep into the sinuses that allow alignment with the native anatomy, that minimize valve depth into the outflow tract, and that clip onto the native valve for fixation. So the device is set and oriented, it is seated properly, and then it's finally sealed. It has the attributes of protecting the coronary ostia. The pacemaker rates have been low, PVL has been low, and the valve hemodynamics for a short frame self-expanding valve have been truly excellent. There are ongoing trials both in the US and in Europe shown here. In the ongoing study that we're involved in, there have been 96 patients already that have been treated, and 70 are going to be presented at PCR in a few weeks. Just a snapshot, these are somewhat younger patients. They're high-risk patients. And if you compare this to the earlier Yoon results, all-cause mortality has been a lot less, device success has been a lot higher. So I think we're progressing in this new indication of aortic regurgitation. So this has been a journey for me. This is the first patient I treated with a transcatheter heart valve, and this is a 92-year-old man with critical AS who couldn't walk across the room and was playing golf in Palm Springs 1 month later. We're still treating these patients, but we have truly progressed over the past decade with expanded indications and an evolved technology. And we're treating patients like this, a man in his young 60s. This is the first reported case of outpatient, same-day TAVR that was done in Montreal, Canada, a few years ago. And you see he's showing at 5 p.m. he's being discharged after being admitted at 9 a.m. earlier the day. No one could have imagined in the early days that we would be doing same-day TAVR. And in fact, in speaking to my friends at the Cleveland Clinic, they now have an ongoing project, and 1/3 of their patients are being discharged in the same day after TAVR, just to give you a sense as to what the evolution has been. So we're very excited to, I think, share not only what we've been able to accomplish, but where we're going with this exciting technology in the future. Thank you very much.